normal control. So therefore, it reduces the risk of microvascular complications and may enhance the quality of life and may reduce, of course, vascular complications also probably. But there are many challenges like weight gain, height is in not only the fasting plasma glucose, but also the postprandial. And this is the famous if you reduce the fasting, you actually can reduce the total glycemic burden throughout the day. Therefore, basal insulin has become what is the ideal basal insulin that you want to use? It should work for 24 hours or more than that. It should be peakless so that it does not produce hypoglycemia, weight neutral, and normalizes fasting plasma glucose by decreasing or inhibiting hepatic glucose production with minimal hypoglycemia. Of course, you should have cardiovascular safety and it should be non-mitogenic, mimic the physiological release of insulin as much as possible so that you get a pretty good glycemic. The first insulin, basal insulin, which is actually really produce an increased cardiovascular risk, but it did not. So insulin was first time proved to be safe from the cardiovascular point of view. Basal insulin did not, the co-primary and the second primary and all-cause mortality was not different in those patients who received glargine compared to those patients who got standard therapy, in spite of the fact they had similar plasma glucose. So there was a glycemic equipoise. As you can see, HbA1c was not very different. And the other fear that we had was whether long-acting insulin like glargine, you may remember there were 3 articles published in Diabetologia some time ago showing that there's an increased risk of cancer in patients who are treated with long-acting basal insulin, especially glargine, based on the data from insurance companies from both in Germany and Scotland. But now this is the first time a randomized control trial going up to 7 years did not show